Okay, yeah. Thank you. Yeah, well, I think let's go ahead with the first speaker. Since there's no other chairperson or panelist, I'm just taking over. So zero contrast PCI. Over to you, Dr. Bari.
Thank you. Good morning to respected chairperson and all the delegates. First of all, let me thank the organizers for inviting me here. And I will be talking on a topic that is zero contrast PCI, which is really getting a lot of importance in the present days, because and also we are getting newer insights every day, and newer softwares being developed on this to aid zero contrast or ultra low contrast PCI. So let us begin with the relevance of this zero contrast PCI. It is mostly relevant for the contrast induced AKI incidence, and the incidence of contrast induced AKI is quite high. It is to the tune of 3 to 15% in different studies. It is associated with increased net adverse clinical events, and it has both short and long-term mortality, ranging from 30 days mortality to an increase in the 3-year mortality as well. So contrast-induced AKI is independently associated with higher hospitalization cost, because you can guess that there will be a prolonged stay, and the patient may need dialysis support. So that will obviously increase the cost. Now, how we can determine the risk, or how we can eliminate the risk, that is very closely associated with the contrast volume to the creatinine clearance ratio. See, the contrast volume to the creatinine clearance ratio, if it is more than 2, it has been shown to be an independent predictor of this complication, that is CI-AKI. And particularly this is true in patients who have a compromised eGFR of less than 30 before the procedure. We consider ultra low contrast PCI when the contrast volume by creatinine clearance ratio is less than 1, and normally a low contrast PCI, which is our target, it is to keep the CV by creatinine clearance ratio to 1 to 3. And today we will be talking about zero contrast, which is basically not using contrast at all during the procedure. This CI-AKI incidence depends on the baseline creatinine, obviously, and if the baseline creatinine is more than 1.5, then you can see in diabetic patients, the incidence is to the tune of 33%, and in non-diabetic patients, it is not very low, it is almost 12%. If the baseline eGFR is more than 45, the chance is really less, and it generally doesn't occur. If the eGFR is 30 to 45, the incidence is 1% higher than the non-contrast group, but the incidence markedly rises when the eGFR is less than 30. This term renalism has been coined in recent times, and renalism means that due to the risk or due to the apprehension of this CI-AKI, the intervention or the invasive approach is taken in lesser number of patients. So the patients, if we divide the patients into those requiring invasive approach, but because of their higher creatinine or because of their higher risk of developing CI-AKI, they are not being taken to the cath lab. So that is called as renalism, and that is obviously altering our results, the outcomes of the patients. Now, there are definitely certain other advantages of zero contrast PCI also, because we know that contrast is a myocardial depressant because of its related hyperosmolality, and because it causes a functional hypocalcemia. And particularly in elderly patients more than 75 years, where the renal reserve is obviously less, so they can tolerate this contrast agent even less. So there are certain situations where ultra low contrast or zero contrast is beneficial, like the CKDs. We know patients taking nephrotoxic drugs, cardiogenic shock, patients having risk of acidemia or hypovolemia, and spontaneous coronary artery dissection. So here, the more you are using dye, you are increasing the risk of dissection extension. And so probably we need to control or reduce the volume of dye. So another set, like the CHIP patients, the high risk but indicated procedure patients, the CTO patients, where we need a longer procedure time and much more injection. So there also the risk increases. Now, what is the real feasibility of this zero contrast PCI? Because most of the studies with zero contrast PCI or ultra low contrast PCI ultimately used a final check angiogram. So it does not remain a zero contrast. It ultimately becomes a ultra low contrast. And most of these studies, they were done where, they excluded the CTOs, the multivessel patients, the multivessel disease patients. But in the real world, if you see the CKD patients, they have more chance of developing a multivessel disease. And many of them will require rotational atherectomy, left main bifurcation, or CTO. So how much this is really applicable to do a zero contrast PCI in such patients, that is really doubtful. Now coming to the procedure and some of the tips and tricks of the procedure. For the access, a femoral access was preferred in most of the cases. Radial artery should be preserved for future dialysis because there is risk of AKI in these patients. And the larger sized catheters should be used because we need imaging devices, physiology devices. I will come to those in my later slides, and we need multiple marker words. So preferably a large bore catheter should be used. So the access should be made in that way, and USG guided punctures were preferred. Now we have to take a diagnostic angiogram. This is angiogram. This is not the PCI procedure. So for the angiogram, we should take a small catheter 5 to 6 French without side holes for better opacification. We should minimize the number of projections because there also we need to minimize the dye load. And to visualize the left coronary artery, the epicranial and epicaudal projections are best. To see the RCA, the LAO oblique cranial views are probably the best. So if you can minimize the imaging by 2 or 3 images, that will reduce the dye. And you have to avoid panning, use low magnification, because these angiograms will be later used as a roadmap. Diluted contrast often, we prefer diluted contrast, but that is a wrong notion, because if you, that may hamper the opacification or visualization of the arteries. So that will ultimately affect your roadmap. So that should not be done. It should not be at the expense of luminal opacification. Using higher frame rates help the operator to maximize the visualization of the coronary anatomy to help detection of calcification. So use higher frame rates in such situation. When there is a doubt regarding the physiological significance of a lesion, rather than taking different views at different angles, use other techniques like intracoronary imaging or coronary physiology to ascertain whether your lesion really needs intervention. If PCI is required, it should be preferably performed as a staged procedure after 7 to 10 days, if possible. Now, during the PCI, we have started a zero contrast PCI. So first thing is to engage the guide catheter. For guide catheter engagement, we have to choose larger catheters without side holes, again to accommodate multiple wards and imaging catheters. Coronary calcium can be used as a guide to identify the ostia and the silotes. And whether our catheter has been engaged, we can confirm by infusion of 10 to 20 ml of 0.9% NS, a cold saline, through the catheter. That will induce some STT changes. Sometimes it can cause a T wave inversion, or sometimes it can cause a increased T wave amplitude as well. Now, word navigation. When the coronary anatomy is already known from the angiogram, from the diagnostic cine images, they should be displayed in real time on a separate side-by-side monitor during the PCI, and that can be used as a roadmap. The dynamic coronary roadmap is a software which is developed by Philips, and there are certain other softwares by other companies as well. If your cath lab is installed with that, that will help you to see a dynamic roadmap. Multiple guide wires will be used to recreate the coronary anatomy by wiring the main branch and the important side branch, and ultimately creating a metal silhouette. Use guide wires without hydrophilic coating and try to give a shape to the tip so that once it crosses the lesion, you can easily knuckle it or form a loop, and that will not damage your distal coronary bed. So this is how a dynamic coronary roadmap looks. So you can see on the right-hand panel, the dynamic roadmap, and through that dynamic roadmap, it is easy to pass your wire. And this is how a metal silhouette is done. You can see main LED being wired, and you can see there is a septal, a major septal, sorry, the LCX is being wired, and you can see a major WEM and its side branch is being wired. So if you are going to stent the in between the mid segment, so you can easily place your stent from the proximal wire to the distal wire, and that will be quite ensuring to cover the stent. If you are going for a auto-osteal lesions like the RC ostium here, if you can keep a wire in the aortic sinus like this, so that can help you identify the auto-ostium, the RC ostium in this case. So the marking wire technique aids in determination of the proximal and distal landing. This is a slightly different technique where you are using two guide wires via double Y connector. I will show you, and a 7 French guide catheter. The main operating wire goes to the distal bed, and the other marking wire is inserted from the side port. And this marking wire, the radio opaque portion, that will act as a guide to identify the proximal and distal marking zone. And that has to be ascertained by IVUS, and IVUS will confirm the distal landing zone. The marker wire will now be pulled back to the level of that landing zone, and by closing the connector side port, the side Y port which we have taken, and if you apply a torquer tightly just outside the side port, so there is no risk of dislodgement of the displacement of this marking wire. So this marking wire with the radio opaque portion will show you the area or the landing zone, and accordingly you can place your stent. The lesion length and proximal landing zone determined by IVUS, and when the stent is advanced, you have to pull out this wire before you implant. So this is how it is done. See, this RCA has a tight lesion in the mid part. So you have done a IVUS to ascertain the landing zones, and you have placed a second wire, the radio opaque portion, the proximal and distal tip going into the proximal and distal landing zone. And you have taken a double Y connector. See the torquer there. The torquer is fixing the second wire from the side branch so that it does not move, and then you can place the stent and deploy it. Now, intracoronary imaging and physiology has to be integrated in such procedures in order to perform a zero contrast PCI, and that helps to perform the PCI safely and optimize the result. And the studies have shown that use of IVUS and intracoronary physiology is associated with lower rate of MES. IVUS has traditionally been the intracoronary imaging here because OCT is not possible, that requires dye, so we have to rely only on IVUS. And then we can, from IVUS, we not only ascertain the landing zones, we can assess the plaque characteristics, the lesion length, the stent length, the vessel sizing, and obviously after PCI, we can optimize the result. So what is done, this is called co-registration of the intracoronary imaging and physiology. This is a separate software which is available by some companies. The mostly known software is Sync Vision Precision Guidance System by the Philips Volcano, and it is currently commercially available. It integrates the data of IVUS and IFR, and what they do is they plot certain yellow dots based on a 0.01 IFR unit of step. So when you are doing a IFR pullback across the vessel, the each 0.01 in step up in the IFR is plotted as a yellow dot. I am showing you in the next slide, and that plots, if you join, you can assess the area which you need to stent. So this is how the dots are placed, integrating the image of the IVUS with the IFR pullback. You can mark the points where you need to land your distal and proximal marker of the stent. This is another example of how this co-registration technique, the wire marking and co-registration, helps you to exactly identify from where to where you have to put in a stent. So by integrating all these techniques, you ultimately lead to a successful PCI. And how do you assess that whether it is optimal, your procedure is have attained optimal results? So for that, again, we rely on IVUS. The criteria standardly used is MSA of greater than 80% of the mean stent area.
You have to wrap up a bit.
Yeah, just one minute, just last slide. So proximal and distal reference lumen, if they are available, more than 80%, only the distal reference lumen, if it is available, then MSA has to be more than that. And the stent area, we know about this 6, 5, 6, 7, 8 rule at the left main bifurcation. We have to see for no dissection, edge dissection or malapposition. And there are also criteria for the significant edge dissection, like it has to be more than 60 degree and more than 2 millimeter of length. Significant malapposition when there is a gap of more than 0.4 millimeter with at least 1 millimeter length from the adjacent wall. And this is important. What is CI-AKI? It is defined as an increase in serum creatinine by 0.3 within 48 hours of contrast medium exposure, or a 50% increase within 7 days. This is the KDIGO working group definition. So obviously we have to combine all these, the techniques of engaging guide catheters, the IVAS co-registration, the physiological assessment, the wire marking techniques, and ultimately we can land up into a good end result. Thank you.
Thank you.